Hey guys, welcome back. The topic that we're gonna study now is congenital tubulopathies, and the highlight of this tubulopathies would be salt wasting. So let's have a look at the first one, that is called as Gitelman syndrome. The disease will be affecting the distal convoluted tubule due to genetic reasons. Let me just hand draw this before you. In a simplified fashion, we can take this to be the sodium chloride co-transporter. You are very well aware that the kidney is responsible for maintenance of electroneutrality. So if it's gonna be one positive charge coming in along with this one negative charge, then the electroneutrality is maintained. What I've drawn before you is the sodium chloride co-transporter, and you very well know that whichever direction salt will go, water will also follow. And if thiazides are gonna block this particular sodium chloride co-transporter, then you would be having diuresis in the patient and even a salt loss. Important transporter coming up now is called as TRPM6 transporter. This is responsible for magnesium reabsorption via the distal tubule. Now, why this is important is because magnesium plays an important role in release of parathormone from the parathyroid gland. Therefore, magnesium plays an indirect role in maintenance of values of calcium. How this calcium values would be affected can be felt in the following fashion, that if TRPM6 will not function, assume the fact that this is not functioning due to genetic reasons, then there will be magnesium wasting in the urine. So I can use the word hypermagnesiuria. But the point is, if magnesium will be lost in the urine, then coming back in the body will be less. If there will be less magnesium coming back inside, then PTH release will also be less. If PTH release will be less, calcium values will be lesser, and therefore tetany will usually be described in clinical features of Gitelman syndrome. And tetany is not a feature of another congenital tubulopathy that I'll explain to you subsequently, that is Barter syndrome. So let's work on this particular disease. Well, the pattern of inheritance is autosomal recessive, and therefore one of the highlight of all tubular disorders will be salt wasting. Just like you guys are comfortable with the fact that hematuria is a hallmark feature of glomerular damage, I am saying whenever there's gonna be damage to the tubules, because I said the word congenital tubulopathy, genetically acquired, so congenital tubulopathy. So whenever tubules are going to malfunction, there's going to be salt wasting, which will explain polyuria present in these patients. However, the question will not describe the term salt wasting polyuria, because then it will make it easier for you to pick up, because the moment he starts describing in the stem of the question these terminologies, you will understand that he's talking about a disease of the kidney tubule and he's talking about a child. So you might be able to figure out the disease process. So therefore he will begin by describing a child to you, let me say 1 month of age, and he has been brought to you with complaints by the mother that the weight is not increasing. You see, water forms an important component of our body. 66% is the total amount of water in your and my body. Neonate, it is going up to 80%. So if the child will pass large amount of urine, therefore child will become dehydrated and his weight will also be lesser, the weight gain will also be lesser. So they will use the word FTT, that is failure to thrive. And when the mother complained that the weight of the child is not increasing in a well baby clinic, let me say I was the resident on duty, so I decided to examine the child and I found that this child was having dehydration. The moment I saw this dehydration in the form of sunken eyeballs or sunken anterior fontanelle, dry oral mucosa, the impression that he will try to give you in the MCQ as well as in real practice would be that you will think that the child is having loose motions. You see, most of the time, whenever you read the terminologies that I've written at the moment, ranging from dry oral mucosa to sunken anterior fontanelle, the first thought process of yours is child is being maybe top fed by the mother, which is contributing to diarrhea with severe dehydration or more, some dehydration, as a result of which these findings are present. So I asked the mother, ma'am, is your child having loose motions? And she categorically shook her head and said, no, doctor, my child is not having any loose motions, but he passes large amount of urine frequently, that I have to change the diaper on a recurrent basis, or nappies of the child. Like diapers are a little expensive in low socioeconomic. I mean, you may not be having a couple having sufficient amount of money to put up a diaper, but the weight is given in the textbook. I just want to say that because this child is having passage of large amount of urine, so therefore diaper change frequency will definitely be increased in this case, or nappy change frequency will definitely be increased. Now, point number 4 is a direct impact of point number 2, because after all I said dehydration in the child. So this is going to cause activation of the RAS system, and therefore one, you have to remember that Barter and Gitelman both are examples of secondary hyperaldosteronism, and action of aldosterone you very well know, but still for the sake of completion I'll just highlight this before you. This is the receptor for aldosterone. You very well know the name, epithelial sodium channel. So this channel is going to work more than normal. Why? Because RAS is activated. The good news is the body is trying to get back the salt. You see, via the tubules, earlier I was saying that there was a loss of sodium, but now the body is also trying to get back some sodium also. So that's advantageous to me. But the bad news is correspondingly there will also be urinary loss of potassium as well as urinary loss of hydrogen, and therefore from point number 4 the exam will definitely incorporate this term hypokalemic metabolic alkalosis. Though there are multiple causes of hypokalemic metabolic alkalosis ranging from chronic vomiting to even I would say healed peptic ulcer disease, carcinoma stomach, but today I've explained to you that even in Gitelman syndrome, hyperaldosteronism will explain the hypokalemic metabolic alkalosis. Or another way the examiner can put this up, especially the hypokalemia component, would be that the child will be having poor cry, because whenever you are examining a neonate you would be checking for reflexes also. So one of the common reflexes that you check is Moro's reflex. So the question might say this child is having poor cry with sluggish Moro's reflex, and that is basically a manifestation of hypokalemia. More importantly, because this disease will be having magnesium wasting, and I explained to you verbally earlier, magnesium is responsible for release of PTH. If I'm going to lose magnesium from the body, the PTH values will be lesser. If PTH values will be lesser, the values of calcium will also be lesser. Therefore, carpopedal spasm can come up. Neuromuscular excitability will be increased. Whenever calcium is lesser, neuromuscular excitability is increased. So, tetany-like features could be described, or you might just say tetany. So, I definitely want you to remember hypokalemic metabolic alkalosis and tetany as one of the important features which are encountered in these patients. And if he wants to incorporate pharmacology here, then I can just say that if thiazides are used in excess in any patient, the same manifestations will occur. Thiazide excess, the pharmacologist would have taught you metabolic alkalosis, and I provided the reason here. That's a secondary hyperaldosteronism, and then subsequently metabolic alkalosis will occur. Let's now have a look at the workup of these patients, and a very interesting test will come up here which has to be remembered. The first and the foremost test, however, that I'll do will be electrolytes, because in any kid with dehydration, failure to thrive, sunken anterior fontanelle, I want to see what is happening to the sodium and the potassium values. And when I had a look at the sodium and potassium, both were lesser. You see, if sodium and potassium are going in opposite direction, let's assume that you are getting a question in the exam where sodium is more, potassium is less, vice versa. Arrows are going in opposite direction. You can always blame aldosterone for it. However, in this particular condition, what's the primary defect? The primary defect is not aldosterone. Aldosterone was coming into the picture secondary to the fundamental problem, which was that this particular patient would be having loss of sodium in the urine, which will be much more than what the compensation can take care of. Because lots of people message me, sir, after all there was a compensatory release of aldosterone, so why is not sodium normal? The point is the pathology process will override the physiology process. As a result of it, the sodium values will be lesser, the potassium values are lesser anyway because of increased aldosterone. So the message is, if in any question sodium and potassium values are going in downward direction, that means that the problem is in the tubules. Because when it's going to be the glomerulus, remember, every time there is acute kidney injury, there is a hyperkalemia. If there's a chronic kidney disease involving obviously the diabetic nephropathy glomerulus, there is a hyperkalemia. But if sodium and potassium both are going down, that implies that the problem lies in the tubules of the kidney. So that's one important observation I want you to remember. And then I will also check for the urine osmolality of this patient, and I will notice that the urine osmolality will be lesser, primarily because there would be a lot of water loss. And third important test that I would like to do, and that was the test I was talking about, that is 24-hour urinary chloride. Now why that's important is because we tend to read about sweat chloride. All of us know cystic fibrosis. So just like you guys are comfortable with the word sweat chloride, I want you to be comfortable with the word urinary chloride, and 24-hour urinary chloride in these patients is elevated. So whenever you read this term 24-hour urinary chloride is elevated, reason I just explained to you, you can have a look at the sodium chloride co-transporter here. So the chloride loss will be occurring, and this patient will be having a chloride non-responsive alkalosis. Why I'm saying chloride non-responsive alkalosis? Why? Because normal saline will not treat this guy, no? Normal saline is not going to treat this guy. In fact, there's no definitive treatment for the disease per se. We will try to give electrolyte replacements. We will try to give higher amount of salt to these patients. But if the tubule is defective, we can't retain it. So there's no definitive treatment for these patients. And since the patient was also having features of tetany, so serum magnesium values will also be done and the values will turn out to be lesser. There's no definitive treatment for this congenital tubulopathy. And most of the time in the exam, when he will put up this question before you, for this congenital tubulopathy, he will just want to see that are you aware that this patient would be having features of tetany along with hypokalemic metabolic alkalosis, and some of the findings that I said definitely mimic that of thiazide excess. Now let us compare this with Barter syndrome. Now this time the pathology would be present in the thick ascending limb of loop of Henle. The reason why this will develop is again autosomal recessive. So let's have a line diagram representing some of the important transporters present here. The first one that I'm drawing before you will be sending in sodium, potassium. So two positive charges are coming in. Then to neutralize these two positive charges, two molecules of chloride will also come in. So I'm talking about sodium, potassium, chloride co-transporter, and along with this obviously water will come in because that would be a passive movement along with salt. Then we have another transporter which will be responsible for bringing in potassium, and then a third one that I have shown. This one is mainly for bringing in chloride. So once again you can see for a positive charge or negative charges coming in, and therefore electron neutrality will be maintained. In fact, for the chloride channel which is present here, I want to bring to your notice that a similar kind of chloride channel has also been documented to be present in the inner ear with respect to the cilia, and because this chloride channel of the thick ascending loop of Henle is malfunctioning, the one in the inner ear will also be malfunctioning, which explains the fact that why in the antenatal format of Barter syndrome you always read about sensory neural deafness. I want to repeat this fact. The channel is common between the kidney and the inner ear. As a result of it, the malfunction contributes to development of not only a chloride loss in the urine. So 24-hour urinary chloride will be elevated in this condition also, and even a sensory neural manifestations will occur. In fact, there's another term that we always read in especially pediatric books but not given in medicine books, is hyperprostaglandin E syndrome. This is itself a term that I want you to remember. Hyperprostaglandin E syndrome is used to describe one of the severe varieties of Barter syndrome. That's the antenatal variety, and I'll just explain to you how this antenatal form will be presenting per se, and you can understand that what's going to happen in this case is that there would be loss of salt, there would be characteristic salt wasting, there was going to be water loss. So therefore the baby will be passing more urine even before he's born, and this urine will contribute to development of polyhydramnios. So lots of time, if they want to make Barter syndrome easy for you to pick up in a multiple choice question, they might actually mention that before this baby was born, the mother had definitely troubles with gross abdominal distension in her pregnancy, and ultrasound had shown that she was having a high amniotic fluid index, polyhydramnios, and they can interlink that with the AFI values that you read in OBGY. Now the standard features will anyway imply for this particular case also, because if these transporters due to genetic reasons will malfunction, you will still be having salt wasting, and the question will then describe failure to thrive. The same feature which I mentioned, the mother brought a child and her concern is, sir, my baby is not gaining weight, and when I examined the child I found evidence of dehydration. Because of this dehydration, the RAS system once again kicked in. So this is again an example of secondary hyperaldosteronism, which will contribute to hypokalemic alkalosis. And I want you to pay attention to the fact that in this condition, the hypokalemia will be more severe than the one that is seen in Gitelman syndrome. Why? Because here the problem will be, even you see, if I just put crosses here, I'm just saying that all of them are malfunctioning. So you are not only gonna be having urinary loss of potassium due to aldosterone. Remember I told you function of aldosterone on the previous slide. I'll just show it once again to you. You can see that there is a substantial urinary loss of potassium. So this is one of the reasons for hypokalemia. And the second reason will be the defect of this particular transporter that I am just highlighting at the moment. So hypokalemia that we get for patients of Barter is relatively more severe. and therefore poor cry, sluggish burrows are the standard features. I mean, on a comparison mode, the hypokalemia component will be more severe. And for hypokalemic alkalosis, there's a possibility that he might write the word chloride non-responsive, or instead of chloride he might say the word saline. At this juncture, if you are not comfortable with point number 4, I would like you to just make a note of it at the moment and go back to the video in the, rather the first one in the kidney, that's electrolyte imbalance that I've discussed, and I've highlighted metabolic alkalosis there, which is of two varieties, saline responsive and saline non-responsive. Saline means normal saline, sodium chloride, right? So that's why I said chloride / saline non-responsive, because obviously this is not going to be a routine case of vomiting that you're going to be giving normal saline to the patient. So therefore these congenital tubulopathies are examples of chloride / either of the two can be written non-responsive metabolic alkalosis. The hypokalemia component anyway will be relatively more severe. Additional fact that I want you to remember for these patients is that the crosses that I have put in the upper part of the diagram, I'll just focus on these channels at the moment. These are the channels that I'm talking about: sodium chloride co-transporter, along with that I'm talking about potassium chloride independently getting absorbed. So the point is, all these channels are responsible for generation of voltage gradient. In fact, I want you to listen to this very carefully. Point number 6 of the discussion, I said all the channels that I've represented here are ultimately responsible for creating a voltage gradient in the kidney that helps in calcium reabsorption. Like you are aware of the fact that proximal convoluted tubule is responsible for reabsorption of phosphate, I want you to remember the fact, just like you are aware of the fact that the proximal convoluted tubule of the kidney is playing an important role in phosphate reabsorption. At the moment I'm talking about calcium reabsorption, and because these channels are malfunctioning due to genetic reasons, so this voltage gradient will also be defective. If the voltage gradient is defective, then calcium reabsorption will be occurring lesser than normal, and therefore you will find that MCQ will describe hypercalciuria. You see, if you are paying attention to the discussion, you will notice that when I was describing Gitelman syndrome to you, I was saying the word magnesium wasting. I had described a straightforward reason: TRP M6 malfunction, magnesium wasting. But this time it was slightly more tricky in a sense. I said that these transporters above are responsible for generation of a voltage gradient, and therefore this voltage gradient would anyway not be generated, so calcium would be lost, and therefore there would be a hypercalciuria developing in patients of Barter syndrome. And how would he describe this hypercalciuria? There can be two ways. I'll just enumerate them. One possibility of describing hypercalciuria can be that this child subsequently will develop kidney stones. I mean, in a pediatric age group, to have calcium based stones looks a little far-fetched, but is true for this condition. I mean, in adults we obviously read about kidney stones, but a child having in the first year of life developed a kidney stones, yes, that's a possibility with Barter. Or because there is a urinary calcium wasting, so the manifestations would be written as that of renal rickets, and therefore you could be having delayed dentation, or you could be having a delayed closure of the anterior fontanelle, all those aspects that you read in pediatrics. The message here is hypercalciuria is an important feature that you will encounter in patients of Barter. At this juncture, the query of most of the doctors is that if you are saying there is going to be loss of calcium from the urine, then why are you not having tetany in the patient? Logical question. If you're going to be having loss of calcium in the urine, you should be having tetany. You would have seen so many patients who are having calcium based stones in the kidney. Do they have tetany? No, na. So the point is, the amount of calcium loss in the urine is not so substantial to the level that it will contribute to tetany. For tetany to occur, the ionized calcium should decrease substantially. Serum calcium should go to less than 7. Some books say even go down to as little as 6 mg/%. So the point is, for tetany to occur, you need a substantial loss of calcium. Here, hypercalciuria does not cause such a substantial loss to cause development of tetany-like manifestations. So we don't get tetany for these patients. And as far as the workup of Barter syndrome is concerned, the first thing that I'll do in any dehydrated child would be serum electrolytes. I'm gonna be checking for the sodium and the potassium values, and I am gonna notice that both the arrows are gonna go down in the same direction. There would be hyponatremia, hypokalemia. I've already explained, whenever there's a tubular disease, I mean both arrows go down simultaneously. And then I'll also check for 24-hour urinary chloride. This is the second time in today's discussion, this particular segment of the app, I've talked about urinary chloride being elevated. Last time I said Gitelman, now I'm saying Barter syndrome. Both are examples of congenital tubulopathies. So to differentiate between the two, what can I do? I can get serum magnesium done. You see, after all, in Gitelman, there's going to be magnesium wasting. So definitely magnesium will be low. But in this case, magnesium is turning out to be normal. So I'm saying, okay, fine, man, no issues. Let's do one more test. In the same 24-hour collection, we can also check for 24-hour urinary calcium, and the values will be found to be elevated. And since I mentioned that in the antenatal format, there is increased amounts of prostaglandin E, which is found in the blood and then even in the urine of the patient. So therefore, for especially the severe variety, they have documented that indomethacin will be useful. Indomethacin will inhibit prostaglandin synthesis, and therefore you will be having improvement. I'm not saying that the patient will be cured, but at least the severity of electrolyte imbalance, the hypokalemic alkalosis developing in this patient, the hypercalciuria component will become relatively lesser. And along with this, especially in a hot Indian summer, these patients will be very prone to development of dehydration. I mean, this kid, if they develop a diarrhea with dehydration, they're already losing electrolytes in the urine. The chances of these patients dying will be relatively higher. So the message is there's no drug documented to show any improvement in Gitelman syndrome, but in Barter syndrome, indomethacin has been shown to at least, reduce the severity of manifestations. Now, before we go forwards and discuss Liddle syndrome on the agenda, it would be a good idea to actually compare the two. So even if you're having printed notes, I would suggest you at the moment to just grab a pen and a paper and note down these details with me so that you develop a permanent memory for these two congenital tubulopathies. Reason why I'm discussing them is because they are ultimately having salt wasting, there's a polyuria, and we also read about polyuria and diabetes insipidus. So I will follow this discussion. In the later part, I'll talk about diabetes insipidus versus SIADH, but the objective of this discussion is to talk about diseases which are affecting the tubules and thereby contribute to substantial amount of polyuria in a person. Gitelman will be distal converted tubule defect. Both are autosomal recessive. This would be TAL defect. In fact, furosemide in excess can cause Barter-like manifestations. Thiazides in excess can cause Gitelman-like manifestations. We will now look at some common findings between the two. One of the important findings would be failure to thrive. Then we will talk about frequent changing of nappies of the child or diaper of the child. There will be evidence of dehydration described in the form of Sankar anterior fontanelle. Electrolyte imbalance will be present. So there is a possibility that if you read the question carelessly, you might think that this child is having water losses from the GI tract, whereas it's from the kidney that the water losses are occurring. And then the differences would be enumerated in the fact that in Gitelman syndrome, there's a magnesium wasting, so hypomagnesemia. If he does not want to talk about hypomagnesemia, he will definitely talk about increased neuromuscular excitability. On the right hand side, however, there is no tetany. Calcium wasting is occurring, but it is not substantial. The word is, it is not substantial enough to contribute to development of tetany. This calcium wasting can result in two profiles. Either you could be having a kid having nephrocalcinosis, or features of rickets could be described. I mean, he will not say the word renal per se, but the point is rickets like features could be described in the question. And one of the common tests that would be done on both the left as well as the right would be 24-hour urinary chloride value. So just like you were comfortable with sweat chloride, there's a separate discussion on cystic fibrosis. I know you have read it in other subjects, but do listen to the medicine component for that also. 24-hour urinary chloride would be increased. Left side, no treatment, but for right hand side, especially the severe one, the antenatal one, which can contribute to polyhydramnios, indomethacin has been shown to be useful. And over and above this, sensory neural deafness, if he wants to give, I mean, I'll just put it up here. Yeah, this makes it very easy actually. The moment he talks about sensory neural deafness, most guys are able to crack the question related to Barter because he talks about a chloride channel defect. So this may be given, may not be given, but the remaining facts that I've highlighted definitely have to be remembered. And if he says what happens to the blood pressure values in these patients, then blood pressure in these patients can be normal, it can be lesser but never elevated. You see, I described two conditions having excess aldosterone. The first time you read excess aldosterone, what is the impression in your mind? Elevated blood pressure. But here, because there was a salt wasting, and that salt wasting is overriding the physiology. See, I said the pathology will override the physiology component. So because the salt wasting is in excess to what the compensatory system can work, that is why BP can either be normal or will be lesser, but can never be increased in these patients. Let us now compare this particular information that I mentioned with Liddle syndrome, and I'll just this also gives me an opportunity to just mention that there are a couple of times in the app when I've said indomethacin can be used. The first time I mentioned indomethacin was especially in a preterm child with the patent ductus arteriosus. If it's not going to close to oxygen supplementation, then I will have to go in for pharmacological maneuver. Indomethacin will also help in treating the podologia or podagra that we see with acute gout. In fact, it can be so severe it might look like cellulitis to you, but when you do a joint aspiration, you very well know it's turbid, but then you read about negatively birefringent crystals present. Then we also use indomethacin for management of a patient of migraine attack at the moment. I mean, for prophylaxis, dependent on the MIDAS score, you might be using triptans in the patient, but at the moment for acute presentation migraine attack, I will use. And then I've also taught you that for the severe variety of Barter, where you might be even having a presentation in the mother because of the disease of the baby. You see, normally what happens is mother has a disease, so the baby suffers. Normally, mother has PAH, baby is IUGR. Mother uses drugs, the baby can die. But here I'm describing a baby's disease which is impacting the mother, that is polyhydramnios component coming up. So Barter definitely as a disease can be asked in the exam. It's also written in pediatric books as hyperprostaglandin E syndrome. These are a couple of uses of indomethacin that I thought will be opportunate to discuss at the moment. And now comes again a very important topic which I've talked about in hypertension aspect also in cardiovascular system, but it makes it all the way more important because I was talking about salt wasting. So now I'm going to talk about exact opposite. So this is the epithelial sodium channel once again. And the main function of this, you very well know, salt and water reabsorption. I'm drawing arrows which are thicker than what they should be, because what I'm saying is this epithelial sodium channel, due to genetic reasons, is exhibiting a gain of function. Now that's again a surprising statement. I mean, I'm not saying that hormone is more. I'm not saying hormone is more. What I am saying is it is the channel which is working more than normal. So as a result of it, there will definitely be a corresponding urinary loss of potassium and hydrogen. So you can see what I'm arriving at. Liddle syndrome will be having a hypokalemic alkalosis, but you can very well see because there will be more salt and more water coming up in the body. So there will be a development of hypertension. You see, if you are listening to me carefully, Gitelman and Barter, I said no hypertension. BP is either normal, lesser, but this is going to be a specific question that has been asked in NEET PG as well. Which condition do you have hypertension with hypokalemic alkalosis? And the moment you read that, you know that you are in position to answer this as Liddle syndrome, and this is not a problem of aldosterone. Rather, what can happen is by feedback mechanism, because BP is already high due to overworking by the channel, so aldosterone values will decrease, renin values will decrease. So this is all the way more important because I have taught you a condition which is an example of low renin hypertension. So if you're just going to casually read the notes, the first impression will be the printing in the notes is wrong. I did get a couple of messages saying, sir, how is it possible you have written low renin hypertension? Because obviously the chap was not listening to the video. So I said, sir, renin has to be high in hypertension. But the concept is what I've explained to you. The problem is not of the hormone, the problem is of the channel. So therefore, because of the feedback, the renin values will decrease in this condition. And also remember that in this condition, there would be no evidence of any dehydration developing in the patient, unlike the previous two congenital tubulopathies where I said there's a salt wasting, so there was evidence of dehydration present. Now let's look at how to solve this problem of high blood pressure in this patient. You see, the problem is not because of the hormone, it is due to the channel. So I'm going to put on the brakes so that this channel is not able to work in excess. Therefore, what I'm going to do in this case is that I can be using a drug by the name of amiloride, and the moment you use it, you will be able to control the blood pressure of these patients. So Liddle syndrome is an example of low renin hypertension. Next, I will compile before you the number of times I have described hypokalemic metabolic alkalosis. You will notice that some of the causes would be saline responsive and some of them would be saline non-responsive, or in some questions instead of writing like saline responsive, non-saline responsive, they might write chloride responsive and chloride non-responsive. The first time I have described this term is with respect to in endocrinology, where there is an increase of aldosterone. In fact, the topic I have described is primary hyperaldosteronism, where either there could be a tumor in the adrenal gland, Conn syndrome, or there could be a bilateral adrenal hyperplasia. So therefore, there would be enhanced urinary loss of potassium and hydrogen. Then even cortisol can stimulate the epithelial sodium channel. The condition in which cortisol would be elevated can either be Cushing syndrome or can be Cushing disease. The differences between the two are definitely discussed in endocrinology, but the message is cortisol has the capability to stimulate the sex steroid receptor, its own receptor, and even the epithelial sodium channel. Then any patient having chronic vomiting. Examples of chronic vomiting can be in pediatric age group, congenital hypertrophic pyloric stenosis. In adult patient, there could be pyloric stenosis due to healed peptic ulcer disease, and then in geriatric age group, there could be a stomach cancer. All of these patients will be having recurrent episodes of vomiting, therefore dehydration will occur, aldosterone values will increase. Then is in liver topic, whenever there is ascites, you see ascites is after all third space loss. So fluid should be, instead of going in the kidney, it is getting wasted in the peritoneal cavity. So I said redistribution of fluid. If the blood supply to kidney is lesser, GFR will be less, RAS will be activated once again. And whenever RAS comes in the picture, aldosterone increases, again urinary loss of potassium and hydrogen. The number of times I have described ascites is with respect to heart failure. That's his choice, what he can write in the question. It could be cirrhosis, it could be nephrotic syndrome, where there is gonna be decrease in oncotic pressure contributing to ascites. But the message is, whatever be the etiology, ultimately the common thing between all the conditions that I'm writing on the slide at the moment is aldosterone is increased. And today I've taught you congenital tubulopathies. One of them is Barter syndrome, that's going to be defect in the thick ascending loop of Henle. Then I've described Gitelman syndrome, where there's again a dehydration component coming up due to excessive urinary loss of sodium and water. And then is Liddle syndrome, which was opposite in a sense that there was a gain of function per se, but all of these conditions are having hypokalemic alkalosis. So what I have done is, different times in the app I have used this term and I've just compiled it all together. I also want to bring to your notice that in point number 3, I will definitely be using normal saline. Therefore, I will say point number 3 conditions are, or all the terms written in point number 3 are chloride responsive alkalosis, whereas for other conditions we will be using spironolactone. But there are some scenarios where you will not use spironolactone. For all other, like ascites, you use spironolactone. If there is Conn syndrome, you use spironolactone in the patient, but you do not use spironolactone in Barter syndrome. Especially the polyhydramnios component is present in the mother, the severe variety. And then in Liddle syndrome, we are having amyloride. But after all, there is no treatment for Gitelman syndrome. No? So I'm not saying spironolactone is a universal answer, but in all the conditions that are written on the slide, except point number 3, mark my words there, all the conditions that are written on the slide except point number 3 would be classified as chloride non-responsive alkalosis, because you will not be giving normal saline, whereas in point number 3 all the conditions, the dehydration component can be corrected by normal saline. So that would be examples of chloride responsive alkalosis. Next, we will talk about another disease where there would be presence of polyuria, that is diabetes insipidus. There are 3 standard features that would be present, that is polyuria, which would be defined as urine output more than 3 liters per day. Though in some cases of diabetes insipidus, the urine output can be going to as much as up to 10 to 20 liters per day. Looks very surprising, because when I say that amount of urine output, the first impression is, would there be dehydration in the patient? No, because they compensate this loss by increasing the water intake. So polyuria and polydipsia are 2 features which are present in these patients, and therefore there is no dehydration, since I said the water intake matches with the urine output. These patients anyway will be having problems at night time, so that's a distress from the patient's perspective, that he has to get up at the night multiple times to go to the washroom to urinate. And in pediatric age group, if the disease is present, then they could also be presentation as nocturnal enuresis. Now there are two subtypes of it, that is central and nephrogenic variety. So we will first talk about why is it that the posterior pituitary can be damaged, due to which the antidiuretic hormones would be lesser. The first answer of your would be idiopathic, but after this it could be tumors in the brain, it could be malignant tumor, it could be a benign tumor, then could be post cranial surgery. This is however most of the time transitory, but in some cases if the damage is extensive to the posterior pituitary during neurosurgery, then this could persist for whole life of the patient. Similarly, in head injury, in some cases we find that this might be present for only first few days to months of the head injury, but in some patients it might be lifelong. Then is granulomatous damage to the posterior pituitary, where they love to ask about sarcoidosis. You very well are aware that sarcoidosis can contribute to neurological manifestations. It can contribute to damage to the optic nerve. So you could be having monocular blindness occurring in a patient, which might make you think in terms of multiple sclerosis. And today I've told you that the same disease can also cause endocrinological manifestations. And the granulomatous disorder, which is more common in pediatric age group, is histiocytosis X. This is where you read about that classical Birbeck granules. And then would be arteriovenous malformations. If they rupture and damage the posterior pituitary, there could be Sheehan syndrome, which has been discussed separately, where there could be a postpartum pituitary damage, and therefore the posterior pituitary can also be impacted. In contrast, when it comes to nephrogenic diabetes insipidus, the problem is per se with the V2 receptor. There would be a V2 receptor resistance developing. So the values of antidiuretic hormone in this case will increase. Now, why is it happening? There are two primary reasons that they love to ask you. You see, they will not ask you what is the treatment for nephrogenic diabetes insipidus, which is thiazides, and they know you know it from pharma, so they'll solve it for you. Rather, they will ask you opposite. What is not the treatment? They will ask you what is the cause. So one of the important drugs causing it is lithium. Amphotericin B also causes it, but then before that I want to write two important causes why you could be having a nephrogenic diabetes insipidus, that is lithium and hypercalcemia. Apart from this, among the rarer ones would be sickle cell anemia. I mean, sickle cell anemia can anyway be having sickling episodes, so they could be damage to the part where the V2 receptors are present, that is in the collecting duct, and therefore there is a receptor resistance. Then can be amyloidosis also. So I've just enumerated in this particular case a list of important conditions where you could either be having a central or you could be having a nephrogenic diabetes insipidus. The values of hormone will obviously vary. Whenever there's a resistance, the values of antidiuretic hormone will increase. And we will now talk about what will be the workup of these patients so that we can arrive at a conclusion whether this disease is present or not. The first and the foremost is a collection of the urine specimen, and we usually try to do it over 2 or 3 days. Because why I'm saying that is because when you ask a patient to collect urine samples, especially in government settings, you may not be having proper containers to measure the exact amount of urine, and patient might under collect or the patient might over collect also. So I said just to ensure that the patient is familiar with the procedure, I do a couple of dry runs, and then once the patient has understood what I really want is an exact timing 24-hour urine sample. So this will definitely demonstrate the polyuria component, which I've defined is more than 3 liters, but there is no evidence of dehydration. Now we will need to check the urine osmolarity and the plasma osmolarity simultaneously. At that particular point of time, when you collected the urine specimen, you will check the plasma osmolarity also. The basic concept is in diabetes insipidus, after all, there's going to be loss of water from the body. So loss of water will contribute to dilute urine, and therefore I put an arrow going downwards, urine osmolarity will be reduced. Remember my next statement that will help you in MCQs and will make your life easier. Urine osmolarity and plasma osmolarity have a opposite direction, or they have a inverse relation whenever you gonna be having antidiuretic hormone coming in the picture. Just like I was saying, sodium potassium have an inverse relation when aldosterone comes in the picture. Now you have learned whenever there's gonna be vasopressin coming in the picture or antidiuretic hormone, urine and plasma osmolarity will go the other way around, or you can just work it out logically. also, if you lose water from the body, the word is loss of water from the body, then the plasma will become concentrated. So plasma osmolality will be increased. And at the same time, if I check out the sodium values in the body of this person, you see, after all, there is loss of water, there is a dilute urine being passed. So therefore, if you lose water from the body, then if I focus on the sodium concentration, it will be increased, and he might write the word relative hypernatremia. Along with this, I also need to check out the plasma antidiuretic hormone values, which I've explained will be either elevated in the nephrogenic variety or can be even reduced in the central variety, but polyuria will be a common finding in all of them. But they would definitely love to ask you about the classical name. That is one of the important tests for this condition, that is Miller-Moses test, or we casually call it the water deprivation test. So what I'll describe next before you is that how this test would be done, though in the exam it is unlikely that he will ever ask you regarding interpretation of a water deprivation test. I mean, he can ask that in a super specialty exam, but it is highly unlikely. But let's have a look at what this test will do to a normal person, so that we are at least able to understand how the disease diagnosis will be made. You see, all you're gonna do in this patient is do a water deprivation. Now, how much water deprivation? That's important. So in the textbook, they will describe that you will have to do water deprivation till you get at least 2 dilute urine samples. I'm putting it simple. You see, what you can do is we will do water deprivation, strict one in the patient, till there is at least 3% decline in the weight of the individual. So just like you're aware, no, these wrestlers or these bodybuilders or people in mixed martial arts, before they compete in a particular competition, they have to definitely come down to a particular weight. Like if you are a wrestler, you can participate in a 48 kilogram category or maybe a 55 kilogram category. So these wrestlers, they stop drinking water at all before they actually go in for a weigh-in, and then they subsequently are able to participate in the competition. So a similar kind of strict water deprivation would have done, which has resulted in approximately 3% decrease in the weight of a healthy individual. Now, if you are not going to drink water for a very, very long time to the level that your weight is decreasing, then your urine will become highly concentrated. So I'm just putting arrows here to say that urine osmolality will almost become 4 times of the plasma osmolality. This is what we have determined in settings, that if you deprive a healthy individual, let me say a wrestler, boxer, whatever, to the level that is losing weight, then urine will become highly concentrated, up to 4 times of the plasma osmolality. 2 to 4x here means plasma osmolality. So let me just put numbers here. Let me say plasma osmolality is 280. So I'll just multiply this by 4. So I can say that the approximate values would be around about 1100 milliosmoles. You see, I'm not doing exact mathematical calculation, but what I've done is simply that in a healthy individual, you definitely can be having is a achievement of concentration of the urine. But in diabetes insipidus, if the hormone is not there, then this concentration is definitely not possible. The water will keep on getting lost from the body. So in patients of diabetes insipidus, this concentration will not happen. That's the first point. Point number 2 is, now what you will do is you can give desmopressin, and if you give desmopressin from outside and the urine becomes concentrated, it means there was a deficiency. On the other hand, in spite of giving desmopressin from outside, if there is no change, that means that the receptors are malfunctioning. That means it is a nephrogenic variety. So point number 1 is, if you know the interpretation with respect to a healthy individual, you can definitely work up that in diabetes insipidus, this kind of a urine concentration is not possible. And then you can intervene with desmopressin and check out the varieties. And anyway, the values of antidiuretic hormone would also give you a hint. Another test I can do in the patient is a MRI head. This would help me in especially central diabetes insipidus. So I just want to say that the T1 weighted image MRI head in a normal individual, the posterior pituitary will be visible in the form of a hyper intense signal. But in central diabetes insipidus, because the posterior pituitary can be damaged from causes ranging from, let me say, sarcoidosis, or a tumor, or let me say idiopathic, or let me say a neurosurgery that was done, then that hyper intense signal will be lost. I repeat the fact once again. In a normal individual, the posterior pituitary can be visualized as a dot of a hyper intense signal. This is perfectly normal for all of us. but in patients of diabetes insipidus, this signal will definitely be lost. The one that I'm talking about at the moment will be, however, valid for the central variety, not for the nephrogenic variety. Remember, two important reasons for nephrogenic diabetes insipidus, that's going to be lithium and hypercalcemia. Instead of asking you the treatment per se, they love to ask you causes. Now, once we've identified the condition, it will be time for treatment of these patients. So the first treatment that I'm going to do, or the first line drug for treatment of central diabetes insipidus, is anyway straightforward. That is desmopressin. This would be recommended not to be taken in form of nasal spray, but rather in the form of tablets, because nasal spray will act very fast, so it can cause SIADH like manifestations. It can even cause hyponatremia. Remember, this chap was having hypernatremia because water was getting lost from the body. It can cause a reverse manifestation also. Apart from this, you don't need to note the next statement of mine. It is just for telling you that another drug that has been used in these patients is carbamazepine, because this also promotes antidiuretic hormone release, though there can obviously be side effects related to the usage of this epileptic drug, so not very favored. But yes, I mean, this aspect should be known to you that carbamazepine at some point of time has been used for management of these patients. Then for the nephrogenic variety, we'll be comfortable using thiazides, and when I say thiazides, you know from pharmacology obviously how it works, but the bottom line is a non-medico will definitely say, sir, I read thiazide is a diuretic. I am passing 10 liters of urine every day. You want to give me thiazide? Sir, my urine output will increase. I'll say yes, urine output will initially increase, but then that loss of water exaggerated by thiazides will force the proximal tubule to upgrade the water reabsorption. You very well know, na, up to 70% of water reabsorption can occur by the proximal tubule. So initially when you give thiazides to these patients, there might be an excessive loss of water from the body, but in the long run, because this is going to upgrade, because there's losses of the water from the body, the PCT will try to reabsorb all the water. So the problem is in the distal part of the kidney. You will not even let the water reach the distal part of the kidney or up to the collecting duct, because the proximal converted tubule has reabsorbed all of the water per se. So in the long run, the urine output will decrease. Another drug that can be used for management of these patients is indomethacin. So you can see a very surprising statement that I'm making. Indomethacin will inhibit prostaglandin production, but it has been shown that it decreases urine output. By inhibiting the prostaglandin production, it can affect the GFR and it can reduce the urine output, so can reduce the distress in the patient. Apart from this, because thiazides are notorious to cause hypokalemia, you very well know that. I mean, thiazides will cause muscle cramps, so we can definitely be using amiloride in place of thiazides. Or if what I can do is, like, we can give thiazides for a duration, then because the potassium values start decreasing, so we can stop it and switch it over to amiloride. So this treatment anyway has to be taken on a long-term basis, but these are the pharmaceutical approaches that I want you to remember, and I want you to read up the pharmacology of why thiazides are used in nephrogenic. I mean, I want you to listen to the pharmacologist's words also, though I have given you the justification. The justification is, yes, it will cause diuresis, I don't dispute that, but the point is, once the water loss will occur from the body, then this water loss will force the proximal tubule to reabsorb all the water. If you absorb maximum water back from the proximal tubule, the water reaching the distal tubule is anyway lesser, and even if there's a problem going from the distal tubule going on to collecting duct, no issues. You have reabsorbed everything in advance only. So we do not get increased urine output with long-term thiazide usage in nephrogenic diabetes insipidus in the absence of antidiuretic hormone. So these are some important aspects which I want you to remember for patients who are suffering from diabetes insipidus. And now we are going to compare this with SIADH, syndrome of inappropriate ADH secretion. Let us now focus on why would this be happening, and the first reason for this would be CNS infections. When I say this, the query from most of the doctors is that, sir, why CNS infections are contributing to SIADH? Isn't that there should be a tumor of the posterior pituitary or of the hypothalamus? That should be the number one cause that you should be telling us. Well, that's not the case. In fact, what happens in patients who are having CNS infections is that they could even be damage to the hypothalamic pituitary axis. You see, antidiuretic hormone in our body is released at a particular threshold. I mean, there's a limit at which antidiuretic hormone would be released. What we have documented is that in cases of CNS infections, the damage to the hypothalamic pituitary axis causes a decrease in the release of antidiuretic hormone. I mean, it will get released earlier than normal at a particular stimulus. As a result of it, overall values will increase, and this is technically called as reset osmostat. The first reason which I would like you to just memorize right now, right here, and they love to ask this. I mean, you will notice lots of times questions of SIADH will begin by describing a AIDS positive patient with opportunistic CNS infection. Look at the linking he's doing. He's talking about a CNS infection which is occurring in a AIDS positive patient, because anyway the immunity component is lesser. So cerebral toxoplasmosis tends to cause damage to the hypothalamic pituitary axis and causes a decrease in the threshold for release of antidiuretic hormone. So as a result of it, at whatever level it should be released, it is getting released earlier than that, and therefore overall the values will increase. Apart from cerebral toxoplasmosis, meningitis and encephalitis should also be remembered. You will notice that in the lecture of meningitis, encephalitis in CNS, I have mentioned that in the treatment part, they should be given less amount of fluids as compared to whatever is calculated maintenance fluid, because meningitis encephalitis patient cannot take orally in the first few days. So you will have to give maintenance fluid. The maintenance fluid that has to be given in meningitis encephalitis patients is 2/3 of the total calculated dose, because they are having SIADH. So that means more antidiuretic hormone means more water in the body. Already there is more water in the body. That is why I said maintenance fluids have to be reduced in patients with CNS infections. Now it is his decision. Whatever CNS infection he wants to create for you, it could be brain abscess in, let me say, the middle cerebral artery territory, contributing to aphasia in a person along with development of fever. So the point is, neurological deficits will definitely be described, but because they're damaging the HPA axis, causing a resetting of the osmostat in the hypothalamic pituitary axis. So this is one of the most important reasons that you should be remembering this disease. And then point number 2 becomes relatively easier, that is ectopic source. Now, there are 2 primary ectopic sources which are to be remembered. One of them is carcinoid tumor. You see, carcinoid tumor itself will cause multiple aspects which have been discussed separately, ranging from 5-HT derivatives contributing to even secretory diarrhea. But lots of time they might be using a pathological term here, because nowadays is I would say integrated questions being asked. So no big deal. I wrote carcinoid tumor initially, but then I remembered one of my students had told me that, sir, carcinoid as a term was not mentioned. What was mentioned in the MCQ was Kulchitsky cell tumor. So that's obviously the cell that's involved here, also called as argentafin cell. Therefore the tumor is called as argentafinoma. And the second important cause is easier to remember, oat cell cancer of the lung. So oat cell cancer can not only contribute to Cushing syndrome, but even SIADH is one of the important paraneoplastic, in fact one of the most important paraneoplastic manifestation of oat cell cancer is SIADH. Then can be drugs which could be responsible. You will find a huge list in which more than 100 drugs will be mentioned. Anti-cancer drugs, especially vincristine, vinblastine, are always associated with the SIADH. Then can be chlorpromazine, haloperidol. These are the older generation antipsychotic drugs, but they are notorious to cause SIADH. And then this anti-diabetic drug is not used anymore, but when you read KD Tripathi or any traditional pharmacology book, you will always read the name of this sulfonylurea, chlorpropamide. In fact, this chlorpropamide was withdrawn because it was causing SIADH. It was also, I mean, one of the initial drugs that was a sulfonylurea category that was introduced, but then was withdrawn from the market because of the side effect primarily, and that's why I have mentioned it here. And then could be even multiple sclerosis. I mean, traditionally, when we read about multiple sclerosis, we read about Uttov's phenomenon. There is optic neuritis occurring in a patient. There could be even spinal cord involvement, and then surprisingly, endocrine manifestation of SIADH will occur, and the overall impact will be SIADH will draw all the water back in the body. So if I just after the causes here draw an arrow to symbolically represent that if you are having excess of antidiuretic hormone due to a CNS infection or due to ectopic source, if all the water will come back in the body, then it will cause dilution of the plasma, and plasma osmolality will reduce. And because of the fact that now water will not be flowing in the urine, the urine will become concentrated. So urine and plasma osmolality will once again be going in opposite directions, as I mentioned before you. So we're going to talk about some important criteria in SIADH which to be followed, and these patients will be having scanty urination or less urine output. The first and the foremost thing that needs to be demonstrated in this person will be that because more water is coming back in the body, therefore the dilutional component will set up and the plasma osmolality will reduce. So I have put up values here. You don't need to remember the values at the moment. I mean, this is just because in the textbook it is written, so I have to come here and describe the mathematical value. I'll give you the value subsequently of urine plasma osmolality, and you know them from physiology also. But the bottom line is there's a dilutional component present. So plasma osmolality will be less and urine osmolality will be increased. Point number 2 is again important, and for this I would also suggest you to listen to the electrolyte imbalance discussion in the starting of the kidney chapter itself in the app. You see, I need to demonstrate clinical euvolemia. I'll tell you how we do that, but first of all you should be clear about the meaning of the word euvolemia. Euvolemia does not mean that total body water is normal. It does not mean total body water is normal. It means total body water is increased, but total body salt is normal. I repeat the fact, in hypervolemia, both are increased. Total body water is also increased, total body salt is also increased. But in euvolemia, it is only water that is increased. Total body salt will be definitely normal. So how do I demonstrate there is euvolemia? There should be no edema in the patient, because if there is a hypervolemia, there would be a periorbital edema, there could be a pedal edema. There should be no ascites documented. Now we can obviously do a clinical examination to check out for puddle sign or for shifting dullness, even do ultrasound. And there should be no orthostatic hypotension. You see the points that I've written here, the first 2 points, no edema, no ascites, those are findings for hypervolemia, hyper, and no orthostatic hypotension, then I can say that this is a finding for hypovolemia. So if none of them is present, all the 3 features that I've written, orthostatic hypotension, edema and ascites are not present, that means neither hyper neither hypo, so it has to be euvolemia demonstrated. The third investigation that would be done in these patients would be a urine osmolality, and as I've explained to you, urine and plasma osmolality will be going in opposite direction, so the urine here will be concentrated. Then I will be checking for urinary sodium. Now this is an important point from MCQ perspective, though it's minor. I would say when we read it, we don't give too much of importance to it, but actually this is important from the exam perspective, that the urinary sodium values in these patients would be elevated. So let me now explain why this urine sodium values are on the higher side. You see, there is more water in the body. So this more water will cause stretching of the atria, contributing to release of ANF. And this ANF will contribute to natriuresis. So though this point is skipped by us in the textbook when we are reading the diagnostic criteria for SIADH, but from the exam perspective, I want you to remember that though the urine is concentrated, it is also having a high urinary sodium. This is not because there is any tubular damage. Like in acute tubular necrosis, I've told you that the tubule infrastructure is destroyed, so salt can't be absorbed. Here I've told you the reason. It is natriuresis which is contributing to, thanks to the more water in the body, that there is a natriuresis component which is present in these patients, which explains the high urinary sodium. The next thing to be done is check out the KFT and the thyroid function test of the patient and the adrenal function also. So let me just jot it down and I'll explain. I said normal thyroid function. Now how that is important, we will just listen to the first lecture of kidney chapter, that is electrolyte imbalance, where I have explained this concept, and I'm just utilizing this space. Before I come back to the previous slide and describe the criteria, I'll explain the concept once again. See, the thyroid hormones also have a check mechanism by which they control the release of ADH. I mean, I'll put it like this, that thyroid hormones also regulate ADH release. If a person is having low T3, T4, then there is loss of ADH regulation, and therefore antidiuretic hormone will start getting released. Once it will be released, the overall amount will start increasing, and when I say antidiuretic hormone is increased, then you can understand that the person will be having more water in his body, total body salt will be normal, so the water will cause a dilution, and therefore In the discussion of hyponatremia, I have explained this concept that hypothyroidism contributes to euvolemic hyponatremia. The message here is that because hypothyroidism can contribute to development of euvolemic hyponatremia, therefore, because this is an important finding which is to be remembered, and even in these patients there can be hyponatremia because there is more water in the body. So I need to be sure whether it is problem due to thyroid or is it due to excess of antidiuretic hormone by itself. So here there has to be a demonstration of a normal thyroid function. So thyroid function test will be done. The next thing which is to be demonstrated normal in these patients is normal adrenal gland function. Now, how will I check for whether the adrenal function is normal? One is a simple way, blood pressure values. Then I can check out electrolytes also, because if aldosterone is elevated, anytime if aldosterone values are elevated, you will be having high blood pressure, whereas in SIADH we do not have high blood pressure. If aldosterone values are increasing in any patient, there will be hypokalemia, whereas you will see in the criteria I will write subsequently, no hypokalemia should be present. And then also I need to perform a KFT of the patient. Why? Because in these patients there was scanty urination. If you look at the arrow that I drew, all the water is coming back. If all the water will come back, there will be less flowing out, so there would be scanty urination. If somebody is passing less urine, your thought process as a physician will be that maybe the kidney parenchyma is damaged. So I will check out serum creatinine of this patient. If I have facility, I will even check for tubular biomarkers, like if tubules are damaged, you could be having elevated values of urinary neutrophil gelatinase associated lipocalcin or kidney injury molecule that I've discussed in acute kidney injury topic. So my objective is I want to be sure. See, in this particular case, the problem is not with the parenchyma of the kidney. The problem is not with the parenchyma of the kidney. The problem is not with the tubules of the kidney. In a sense, the tubule is not defective. It is antidiuretic hormone whose either the threshold of release is relatively reduced, or there is a ectopic production, or like in hypothyroidism, the check mechanism is lost. As a result of it, the values are increasing. So you need to demonstrate a normal thyroid, a normal adrenal, and a normal kidney. I repeat once again, 5, 6, in fact 4, 5, 6 all are important from the exam perspective. How are you going to remember it? In all cases of SIADH, thyroid function has to be normal, adrenal gland function has to be normal, and then urinary sodium would be elevated due to the natriuresis component that comes up. I also in these patients need to demonstrate that there is no use of diuretics, because after all, if there are going to be diuretics present in any individual, that can affect the results for at least 1 week, and there should be no hypokalemia. Why I'm saying that is because if I demonstrate any metabolic alkalosis, I'm writing no acid-base disorder also in the patient should be present, because acid-base disorder, if present, it means aldosterone is at fault. Remember, hyperaldosteronism, you always have a metabolic alkalosis. So my objective of doing all this activity of teaching you the diagnostic criteria is that you need to rule out possibilities of abnormalities related to the thyroid gland, adrenal gland, and a kidney parenchymal disease, and even rule out kidney tubular malfunction, because the problem is with respect to the hormones in the patient. These are the primary criteria that will be useful for diagnosis of this patient, 8 to be precise. Now I will explain to you some supportive evidence which will help you in diagnosis of SIADH and will be given in large number of questions. It's simple straightforward fact that because in SIADH there is more water in the body, the more water in the body will cause dilution, and BUN values can even be lesser than normal. You see, normally I teach you low blood values can be seen in liver disease, because after all blood urine nitrogen is synthesized by liver. And if a person is having GI blood values, BUN values can increase. But the point is BUN values can be less in SIADH also. And similarly, uric acid values will also be lesser, again because of the dilution component that is coming up in these patients. And once I have demonstrated these facts, then subsequently I can be doing the test for these patients, because they love to talk about endocrinology based tests. So that would be a water loading test. You see, in a normal individual, if you're gonna give a particular amount of water, the kidney will be able to excrete it. That's primarily because ADH production will be suppressed, and therefore if ADH is suppressed, the body will lose the water. But in this case, because antidiuretic hormone is more and you are loading the body with water, even the water which is extra that is being given, that won't be lost, because antidiuretic hormone production cannot be suppressed, either because it is being produced more than normal, or there is a reset osmostat which is causing excessive production at a lower threshold. So ultimately, let's look at what will be the treatment for these patients. The primary treatment for these patients will be usage of drugs and water restriction, because after all, if there's gonna be a euvolemic hyponatremia, the sodium values will keep on plummeting in these patients. Then I need to control the misbehavior of the excess production of antidiuretic hormone by treating the cause. Like if it's cerebral toxoplasmosis, I will have to use drugs for management of it, whatever is the etiology behind meningitis, encephalitis, brain abscess. So we'll try to treat the cause, but you see that might take some time. So in intermediary, the step that I'll use would be a pharmacological maneuver where I will try to block the V2 receptor, so that even if ADH is coming more than normal, even if the reset osmostat is causing more ADH to come up in the system, because brain abscess treatment, IV antibiotics might have to be given for weeks altogether. So I can't let the patient suffer for weeks altogether. So what I'm going to do is I'm going to use in this patient a oral drug by the name of tolvaptan. And when I was a student your age, I used to read about dimeclocycline. I'm just saying it verbally, not writing it, because that's old data. So you would have read in older books if you are using older version dimeclocycline, but now we will be using tolvaptan for these patients. And additional information I want you to remember is how is tolvaptan working. Tolvaptan is working by blocking V2 receptor. So another use of tolvaptan that you need to remember is in congestive heart failure patients, if there is a hyponatremia. Remember, hyponatremia means more water in the body. So you can use tolvaptan even for management of hyponatremia in CHF. I repeat the fact once again. Suppose a CHF patient is persistently having sodium values of 120, 125, or let me say a little higher, 128, right? A little respectable value. From the perspective, it's not causing a seizure. I'm not saying it's normal. Normal is 135 to 145. I said 128 on a regular basis. Why? Because there is a dilutional component, because CHF is anyway volume expanded state. As a result of it, I mean, because sodium is lesser, it can definitely contribute to multiple problems for the patient. And I don't want electrolyte imbalance in any patient of heart failure. Like, you know, hypokalemia can occur due to excessive use of diuretics. I'm saying volume expanded state can cause hyponatremia. So what I can do is I can, in CHF patient, go in for water restriction and use Vaptans, because if they will stop water from coming inside, then this hyponatremia component, at least it will not deteriorate and gradually might even come back to normal. So Vaptans will be answered by you for management of hyponatremia and CHF, and even management of patients of SIADH. So towards the end of this discussion, we are going to compare these disorders that I've explained to you. I would suggest you to, at this moment, take out a paper, pen, and listen to the aspects that I say. In fact, draw the table like this. It would be a 4x3 table. Leave 2 blank entries here. And then just put up values for urine osmolality, then plasma osmolality, and sodium concentration. It's sodium divided by water in the body. The bottom line is, in SIADH, I explained there is going to be gain of water in the body. In diabetes insipidus, there is going to be loss of water in the body. So let's see what happens. In SIADH, because there is gain of water in the body, therefore, the plasma will definitely become dilute, but the urine will become concentrated, arrows going in opposite direction. Whereas in diabetes insipidus, if I lose water from the body, then urine will be dilute and plasma will be concentrated. So the first thing that you can deduce right away is that the arrows will obviously go in opposite direction, but you need to figure it out that in diabetes insipidus, loss of water, so urine is dilute. In SIADH, it is opposite. Now let's look at sodium concentration. In SIADH, because there is gain of water, so there will definitely be a hyponatremia present. Arrow is again going down. Whereas in diabetes insipidus, because you are losing water, I said the word relative hypernatremia. Guys, I want you to have the capability to work it out fast under 1 minute, because this is not gonna be like, you know, a separate MCQ. These are 2 options of a single MCQ, and he's gonna confuse with you with increase decrease. What I can say at the moment is, if you can figure out the urine osmolality in the MCQ, half your job is done, because then you need to just invert the values. You can see urine osmolality, plasma osmolality, sodium concentration are anyway going in the same direction. So you just need to quickly figure out. The way I've mentioned is obviously logic here. SIADH, gain of water, so it's going to be concentrated urine. In diabetes insipidus, loss of water, so there is going to be dilute urine in the patient. And now I will make some entries here which are again important from the exam perspective. Like suppose a person is having psychogenic polydipsia. Now this chap, he keeps on drinking water all the time due to psychiatric reasons. So if somebody will keep on drinking water all the time, lots of water all the time, it will cause dilution of all these components and all the arrows will go in same direction. So you will get MCQs in the app or book or whatever that you're using where urine and plasma osmolality arrows will be going in the same direction. Then don't answer with relation to antidiuretic hormone. Let's do it again just to see if you followed me or not. This chap unfortunately had damage to his osmoreceptor. See, osmoreceptor technical name is OVLT, organum, you know from physiology, organum vasculosum lamina terminalis, right? This is the osmoreceptor, organum vasculosum lamina terminalis, and this was damaged post-head injury. So because this is damaged, the person is not feeling like drinking water. You and me in a hot Indian summer, like even when we are on a duty, we keep on drinking water intermittently. If I'm speaking continuously, taking a live physical class before you, after continuous speaking for 1 hour, my throat will feel parched, I will drink water. But in this guy, 2 days have passed by and he's not even, you keep water in front of him, he does not drink it. That's because the osmoreceptor is not functioning. So if somebody will not drink water, it is going to contribute to concentration in the body, so all arrows will go up. The learning point for you guys is that this particular table, I want you to develop a capability to write this table by yourself in about 1.5 minutes. The filling up part, obviously, you know, remaining data will obviously take some time, but if you can just figure out a method like I have here mentioned from my, I would say, visual memory, retained memory, that this table can be worked out fast and I am able to explain it to you, so you should be able to retain it, because these are gonna be 4 different choices of a single MCQ, and a single MCQ is gonna test your knowledge of antidiuretic hormone by incorporating 4 diseases. It will also be important and good idea here that I now mention regarding the normal values, though you know them from physiology, but let's have a look at first of all the plasma osmolality. So different books can have different values. I mean, the ranges can be slightly different, but plasma osmolality does not fluctuate much. It is like 280 to 290. Sometimes it is written 275 to 295 milliosmoles. So that's pretty, I would say, in a narrow range. But urine osmolality fluctuates a lot. You see, the kidney is trying to maintain the osmolality of the plasma by fluctuating its own osmolality. So I'm not talking about urine specific gravity, guys. I'm talking about urine osmolality. Sodium, you very well know, it's 135 to 145 milliequivalents. And then I also mentioned an additional fact, which is not a diagnostic feature right away, but then blood urine nitrogen is lesser in liver disease, and I also described in SIADH patients, BUN will be lesser. Another feature I mentioned was urinary sodium will be increased in these patients. I've mentioned the diagnostic criteria already. I explained the reason for this increase in urinary sodium is thanks to the natriuresis component that comes up. So when he's going to put up those increase decrease values in the questions, endocrinology is all about being able to interpret what becomes more and what becomes lesser. If you develop that reflex at a subconscious level, then you are spot on to solve questions related to the topic. So keep hammering, keep the focus on, and keep learning new facts every day, and you will definitely be able to get very good marks.